So the clinical features, again, when there is a mild or when there is a segmental collapse, it is going to be asymptomatic, isn't it? Only when there is a segmental collapse, it is going to be asymptomatic. When there is a large lobar collapse or when there is a massive collapse, it is going to suddenly cause dyspnea, rapid respiration, shallow respiration. The child could have cough, cyanosis, even chest pain sometimes, and signs. The child will have tachypnea and tachycardia. So physically, when you examine a child who has an atelectasis, you will find that particular area, there will be limitation of chest excursion, that is chest movement will be decreased in that particular area. And when you auscultate, you will find that the breath sounds are also decreased in that particular area along with some crepitations. Okay, so crepitations, and there will be decreased breath sounds. When there is a massive atelectasis, what happens? Sudden event. So this child will definitely have cyanosis, dyspnea and tachycardia. Okay, so this massive atelectasis children will be extremely anxious, and they definitely complain of chest pain. Okay, extremely anxious child suddenly developing, say there is a pneumothorax. It is a sudden onset pneumothorax, and the child is completely, it's a massive pneumothorax. One particular, say the right lobe is completely collapsed. The child will have severe dyspnea, extremely irritable child, right-sided chest pain. So this is the clinical feature of a massive atelectasis. So when you examine that particular side, let's say for example the right side is affected. The right side will have decreased respiratory excursion. The breath sounds will not be heard. It will be dull or it could be hyperresonant depending on what happened. Okay, so if there is a pneumothorax, you can have an hyperresonance also. So this is the clinical feature. So what happens? Say if there is an atelectasis, you know the child is getting affected, but pathophysiologically what happens inside? So there is an impaired gas exchange. Okay, so these are all, there is gas exchange doesn't take place in those alveolar units which has collapsed. Okay, and the collapsed lung will serve as a nidus for infection. So secondary infection is possible, and a long-standing collapse, the lung, that particular area, that segment can go for fibrosis also. So this is the complication for atelectasis. Most of the atelectasis that we see in children is towards the right side, and mostly it is the right upper lobe. So right upper lobe, again, even in intubated patients, sometimes the endotracheal tube can be deviated or can go into the right mainstem bronchus intubation, isn't it? So the right upper lobe is the most common site for atelectasis. In adults, it is the left lower lobe. Okay, so diagnosis, clinically you have, you will know that the breath sound is decreased, how is the percussion, etc. But you diagnose based on the chest x-ray first, and you can confirm it with an ultrasound also. So whenever we do a chest x-ray, when there is a collapse, it can be associated with consolidation, it can be associated with a pleural effusion, there can be a pneumothorax. So whatever pathology is associated with an atelectasis, we can have that idea also. And when there is a collapse only, the mediastinum will be pulled towards the affected site. Okay, so there will be mediastinal shift, there will be volume loss, so crowding of the ribs over that particular area is all possibly seen in a chest x-ray. Lung ultrasound is for confirmation. When there is a massive atelectasis, you can see that the entire right side here, it is completely whitewashed. The mediastinal is shifted towards this side. The hemidiaphragm, although here it is not visible, usually the intercostal spaces will be crowded. See, the spaces are crowded. You are not able to see the diaphragm here anyways, but there can be elevation of the hemidiaphragm also.